I think healthcare data in New Zealand is in a particularly complex environment. So when you talk about healthcare data, there is so much data in New Zealand, a huge amount of data. It's very difficult to access and use it in a meaningful way. And that is because we have been a little bit of a cottage industry for health, really. We have developed our own systems and our own ways of doing things for a long time. That means when you want to connect data together, it's very difficult to do. So we do have a unique identifier within the public health system called a National Health Index number, which is your NHI. But that's not used widely across all health sectors. ACC doesn't use it widely. Southern Cross doesn't even have access to it. So actually, even just taking your piece of data and connecting it when you see your GP to maybe an ACC claim that you made might not be as easy as it sounds. And we also then have those sets of data in very disparate systems. So data is being kept in the majority of times based around a clinical person or a service, not based around you, the person. So your data doesn't move with you. So you might think when you go to hospital to see an emergency doctor in the weekend that he knows about you because he can access your primary care data, but he can't. So you have to tell your story to somebody over and over and over again. And that's because we've based our storage of data around systems and not around people. So there's a lot of work. It's great. It sounds like there's a lot of problems, and there is, but that's a huge amount of opportunity to make a difference. So it's not that we don't have data, it's just that we find it very difficult to connect that data up in a meaningful way. So that's kind of my view on the context.
There's lots of things going on to make those systems be able to talk to each other better. I'll talk about the DHB system because that's what I'm used to, but I'm sure we can talk about fire and snow weather. Yeah, cool. So with the DHBs, there's a whole lot of information that we are trying to synthesise together. I'm at Waitemata District Health Board, and we're leading some of the pilots on trying to get that information together, which is really exciting. And we're working with precision-driven healthcare, so they're part of Orion Health, and so they're helping with trying to incorporate that. So one thing, I'll give you an example. So right now you go to your pharmacist and you can get a prescription medication, and that used to just be in the pharmacies. Only pharmacies knew what kind of medication they dispensed to you. But now we've got a system that allows, called TestSafe, which allows that information to come through onto your hospital record. And so I, as a doctor, can look in, you come into ED to see me, I can jump on TestSafe and I can see all the past scripts that you've had from your pharmacy. And that's really, really important information because I can tell what kind of things you might have been treated with. If you've been tried with a specific antibiotic, I can say, well, maybe that one didn't work, I can try a different antibiotic. And it helps because these drug names are really complicated, and if I'm asking an 80-year-old what kind of drug did your doctor give you, they're probably not going to remember or be able to say it. So that kind of information coming through is really helpful for clinicians. And I know that that particular piece of software to make those systems talk together was incredibly complex and took years to do. But that's an example of something that's been done really, really well. And I'll let you talk about how that possibly could have happened.
Yeah, I think, as you referred to, there is a move towards standards in New Zealand if you're talking about data. So there's a standard called FHIR, which is a health standard. It's basically a template for when I'm giving you a set of data, these fields mean this to you and they mean the same to me. And then there's a set of codes that so an insulin-dependent diabetic code is the same to you as it is to me. So there's a move towards that. But I think I'd like to give you just two brief use cases about where data in New Zealand is actually being used really well. So at a population level, which is an unidentified level, we actually do have some quite powerful data sets. There was a move by the Social Investment Agency, I don't know if you've heard of that agency, but it was under the Ministry of Social Development, where they stood up a data exchange between all ministries, between the Ministry of Justice, Ministry of Health, I don't think was in there. But there was a number of ministry data sets, and it helped inform policy because you could see if employment related to being in prison, related to your socioeconomic status, related to where you were in the Ministry of Social Development, and you could see what was happening at a population level. I couldn't tell it was, say, semi, but I could see where those pockets were, and so it helps form policy around what we might choose to target in our budgets. So at that level, we are doing pretty well in New Zealand compared to other countries. We don't do precision data management very well. But there is some initiatives to try and do that. So another initiative I worked on was something called high-tech imaging in primary care. I was working with primary care and ACC to use data to go, if we moved the ability for a GP to order an MRI for you because you injured your knee, would we know if you did that the right way? Would we know if you made the right decision to do that? And could we use data to do that? And so we built an end-to-end platform that tracked you across a number of different disciplines, from your GP to your radiology provider, and back to your GP to a specialist to see what would happen. And then we were able to make a judgment and say that was a good decision or not a good decision. And once you have the data in that flow and you validated that data, you can then apply machine learning to it to automate that process, which we did. So there's some really good initiatives happening in New Zealand, but they are still quite small. They're in pilot phase. We seem to really struggle to take things out of the pilot phase and move them into scale. But we're getting there and we're moving towards that. The other issue which nobody talks about in data, which is not technical at all, is around the privacy issues in New Zealand. And we talk a lot about, sensitive data and keeping data private, but we don't talk about what happens if you don't share data. So if you turn up at hospital and you're having an MRI, and I needed to know something about you, but I didn't know that because I couldn't share your data and something happened to you, you died. That's actually as bad as if your data was shared, but you hadn't given permission. It can have good benefit. That's going to sound very controversial, and I'm not suggesting we use data without permission, but I am suggesting that we only ever look at the threat of sharing data, we don't look at the threat of not sharing data. So I think there's a really robust discussion to have in New Zealand about what does privacy mean, what does it mean to me, who can I give my data to, do I even know that my data is not being shared when I thought it was, and I think there's a whole lot to unravel in that, which is not technical at all.
So I was sitting around at lunch today with a whole lot of house officers and registrars, and I said, what do you guys think about democratisation of healthcare data? And they all looked at me very blankly and said, what? Democratisation? What does that mean? So I think that, this is an area that is still being understood, and that a lot of people don't really have much understanding of what's happening. But I think personally it's quite exciting. So it means that just like your finance data, just like other data, your health data belongs to you. And you should have permission to be able to read it and to be able to have the opportunity to learn about it. And right now, it's a very big power disbalance between clinicians can write anything they want on notes about you, and you have to get permission from the DHBs to be able to read the kind of notes that we write. And I just think that that's crazy. I really think that we should be able to read them. I want to know what my doctor's writing about me. So I think that this whole this disruption that's coming to the healthcare industry is going to be based on this power being changed. So from the providers holding all the power to now the consumers having the power and saying, actually, no, I want to know my information. It's mine. Please give it to me. And this is going to just upheave everything. So how doctors write their notes, how nurses write their notes, is going to have to change. It's going to have to change in a way so that people with not much medical knowledge can actually read and understand them themselves, that they're free to be able to use that. They can go online and ask for opinions from people overseas. That's part of the... this is a huge topic, sorry. But going back to democratisation, I think that underlying that is the power is going to change, and I, for one, am really excited about that. I really challenge that, and so clinicians quite often will hide behind that and say, oh no, but we can't let them know everything, and you'll use big words like confabulation instead of lying, or we'll say factitious disorders and things like that. But I actually really challenge people to think, how about you have an open and honest discussion with them? If somebody's coming in a drug seeking, I say to them, look, I'm actually concerned that your reasons why you're seeking drugs is not for this health condition, it's because maybe there's an addiction underlying this. And have a free and open conversation, and then I'm happy to write that in the notes and give it to them and say, look, I'm actually thinking that this is my working diagnosis and is an addiction rather than a chronic pain or something like that. Or both together, it's very complex. but I think we need to be more honest.
I think democratization of health data is also across the disciplines. So I think there's been a lot of power held by specialist groups because knowledge is power. And so if you start to share and spread that knowledge across more generalist providers, then you actually start to be able to give more access to people. So you might only have one specialist, so how many people can see one specialist? But if that knowledge that specialist has is shared with 10 other people, then how many people can see those 10? So I think there's a real opportunity in terms of equity and equity of access to start democratising knowledge. There's also some really interesting stuff happening in the AI world with that. So if you're in diagnostics at all, or in radiology, or even in ophthalmology, looking at retina scans, actually you have to think about what is your future, because an AI can read a radiology film or an MRI more accurately than a human being. But can they communicate that message to the human being in an empathetic way? So say that a film finds cancer. You don't want a machine to sit down with someone and talk about what that means to them. A machine can't do that. So it's about what knowledge and what information is able to be automated and what is really important to communicate human to human with empathy. So there's a real shift happening in healthcare, and it's really going to disrupt whether or not we choose to engage with it or not. It will happen to us in the healthcare sector. And so we can choose to be a part of that journey and to reorientate our thinking, or to be impacted by that. So I think democratisation of data is at the personal level, at the clinical level, and at the government and policy level.
What factors would contribute to this healthcare information, like shielding of this healthcare information? Like what is restricting it from getting out to the public? What would you think? What's your idea?
Oh, lots of things. One of them in particular is people's egos. There's a lot of people that would like to act in silos, and I think that sometimes we just need all to get together and get on with it, and that there's been quite a few moves to do that. So, for instance, in the South Island, Christchurch Hospital, they set up Health One, is that right? Yeah, Health One, and so poor old where I trained, Dunedin Hospital, it's fallen down, quite literally. And so they said, great, Christchurch, can we please piggyback on your great Health One software that you've done, and we will collaborate. So now all of the South Island is all on Health One. So they all talk to each other. So if a patient came from Christchurch down to Dunedin Hospital, I could see their health record. Similarly, in the Northern Regional Islands, so that's the 3 DHBs in Auckland, they also collaborate. So I can see notes from Middlemore Hospital, ADHB, and Waimata District Health Board, and that is fantastic. And it really irritates me when I get a patient from Northland or Wellington, and I can't see their notes. And I have to ring up, and then I have to reply, send a fax, guys, we still use faxes in hospitals. Send a fax with my little signature saying, please send me the notes. Then they will print the notes, then they will fax it back to me, or the other day I actually got an email attachment. Yeah, it was very exciting. So some things are still in the dark ages, and then other things are going really, really great. And so I think that, yeah, it'll continue to grow, and it'll continue to talk more to each other. But again, I think that we need to put our egos aside and all sit down and talk about how we can do it as a country, because we're a pretty small country, you know, and I think we could really do something exciting, because we're one of the only countries, as Alex was saying, that has got the NHI number, so that identifier number, that every time someone's born in New Zealand or every time someone enters in New Zealand, they get that unique identifier number, and that's actually quite special for New Zealand, and it makes something that could be nationwide actually achievable. So there was something called the National ID Program, and I don't know much about it, but I know it was on when I was going to second year medical school, so students, so that was like 7 years ago. And they ran it really well. They had like a task force group, and they did a few national programs. And then, like also Alex said, we like to do pilots but not follow through. So a lot of the pilots were doing really well, and yet they didn't have funding to follow through with it. So I think if there's one thing that I would say you could do, it would be to lobby the government to put adequate funding and resource into it.
I do have kind of some ideas around this. I think the government, for a start, is looking at, I don't know if you guys saw the Health and Disability Sector Review paper that came out recently. So they're looking at establishing standards and requiring vendors to meet interoperability standards to help solve that problem. But I also think, and I'm going to declare my bias here for primary care, is that the majority of health data actually sits in primary care. We get very DHB-centric in our thinking, but if you think about how many times you've been to see a healthcare provider, would you be more to hospital or more to primary care? And I include physio and hormone and primary care. So I know ProCare alone, which is where I've been working recently, we do 3.5 million GP visits a year, and it's just the ProCare network with one of the other PHOs. And they have been collecting data electronically for about 30 years. Over the first, in fact, I think we have the largest primary care, might be 20 years, largest primary care data set in the world sits in terms of longevity, not obviously the amount of people, sits in New Zealand. So I actually think there's a bit of EHR by stealth going on in primary care, because actually the primary care sector has been very active in looking at its centrally held records recently, and the majority of the large PHOs are selecting systems that have centralised, standardised data models that allow access via identity control. So the idea that you can turn up a hospital and give a one-time code to you to access your record, which is actually just your one record, means that you're writing into the record, given that access by that patient. It would eliminate the need for referral, because you would just send a notification to the hospital to say, we're recommending a review for this patient, and you just log into the record. So there are other systems in the world that do this. There's a system called EPIC, which was part of a review in New Zealand for the National Electronic Health Record. It's very expensive, which is why we haven't gone down that path, but it does allow you to access a one record. So I actually think that potentially, watch this space, primary care by stealth may be establishing a EHR record just because they have a large amount of data and a large amount of transactions all in one place that's looking more standardised. So, could be a solution. I mean, I think any move towards standardisation and interoperability standards is a good thing. So, will it solve it? I don't think it'll solve it, but will it help? It will definitely help. And I think if we can encourage the vendor and system market to adhere to standards, then I think you obviously will be enabling easier interoperability. I really like, there's a model, a business model that I don't know if you guys have heard of, Canvas, which is a learning management system. I think you guys use it here, right? Yeah. So that's made by a company called, no matter what you think of the platform, it's made by a company called Instructure. And Instructure took Blackboard on primarily around their business model. So what they decided to do was to publish all of their APIs and all of their data endpoints to make it really, really, really easy for you to design third-party applications to enhance that data. And they did that because it made themselves very sticky, because it meant that if you wanted to get that particular piece of function elsewhere, you had to buy an end-to-end system. Blackboard is an end-to-end system. It doesn't allow third-party integration because it doesn't publish its endpoints. Canvas decided to be part of an ecosystem. Now, it's a little bit trickier in health because we have security standards and we don't just want to be going and publishing endpoints that you can just go and access data from. But I think a move towards thinking more around, if vendors could think more around a business model that allowed other functions to easily attach to them, then they would become more sticky. I'm not explaining myself very well, but I guess what I'm trying to say is that if you try and do a solely vertically integrated system that does not talk to an ecosystem in healthcare, it's not going to work. And unfortunately, we have a lot of systems in healthcare that do that. A lot of systems that don't publish their connection points, that don't set themselves up to be interoperable. And that's, I think, one of the biggest reasons why we can't, in New Zealand, keep data sets very well. So will it help? Yeah, it will definitely help. Will it solve it? We've got a long way to go. Yeah.
Wouldn't it be nice if MedTech did what Canvas does?
So yeah, in regards to that, sort of like, what's your perspective on it? Like, through democratization, do you think we'll be able to eventually reach that point? Like, can we actually utilize EHR more in the future and, I don't know, possibly use Canva's business model for health? I know that there's going to be a lot of sensitivity around the data, but what's your perspective on it?
I mean, I think my perspective is that we're shifting that way. And so most organisations who deal with any kind of need to transfer data, PHOs, when you've worked for a while, who understand that difficulty, are choosing systems, deliberately choosing systems that run more along that model. When I was at ProCare recently, I was involved with the selection of their practice management system, and primarily that selection was based on, can it interoperate easily? Does it use standards? Does it publish its APIs? And is it more of a standardised, centralised data model? And so I think there's a lot of thinking in the health sector around that.
And again, I'd just like to raise the issue about ethics when it comes to that, which is going to be something we're going to have to all discuss. And I don't think there's one answer, as that's why it's ethics, and they have a whole department set up to talk about that. Stanford University has just published 10 guidelines for the use of health data. And I suppose that's the first time someone's had a go at writing out some guidelines. And the AMA, which is the American Medical Association, they have taken some of those 10 points from Stanford and incorporated them for clinicians in America as well. So if we're going into telehealth, that's another whole talk, but it's really exciting to see some of the things that are happening. So when I was a nurse, I went and worked in the outback of Australia, and I worked near a mining town, so we were like 2 hours from the local town, and we were a 5 hour flight from Perth, and we did a lot of telemedicine. We had telepsychiatry, so we had psychiatrists who were able to Skype in, because you don't really need to, from a psychiatry point of view, have a physical examination, so that works really well. But what was really cool is that me as a nurse, if I had someone coming in with a heart attack, I'd be like, okay, I'll put the ECG on, get the ECG on, and I'm like, okay, got ECG elevation on the ECG, that's the heart attack. I'd ring up the doctor in Perth and say, hi, I've got an ECG elevation MI, can I please get thrombolysis, which is like a medication to clot bust. And they're like, sure. So I turn on the video camera in the resus room, turn it on, and I put them on speakerphone, and then I'm like, okay, I'm preparing the drug, and I'd hold up the vial, hold it up to the video camera, saying expiry date, 2020, yep, sweet, go, throw it up. And this is just me, a registered nurse in the outback. I was able to give thrombolysis to patients who were having heart attacks and save their lives. And it was all through a doctor on video and speakerphone.
Just to say that virtual health is emerging quite fast in primary care in New Zealand. So I know there are 12 practices that are actively doing that now. We've integrated into the practice management systems, and they offer you either a physical or a virtual consult. And it's really interesting to see how patients choose which one they do. Sometimes for the same thing, one time they'll want virtual, next time they want to come and see a doctor. So yeah, I think that whole convenience model, which I think is what's driving the Dr. Google generation, is that it's actually quite painful to get to see your GP or go to hospital. It's not convenient. Yeah, and particularly if it's just for a repeat script or something that's quite, simple. So I think we've got a long way to go in terms of models of care. It's technology and models of care together, but we're starting to get there. If we don't, it will happen to us anyway.
Can you mention which PMS you are referring to in regards to?
Yeah, so actually all of the practice management systems are enabling virtual consult through their patient portals. What you do is you do the booking through that, and then you go and use something like DocsMe or one of those other more reliable video interface. I do know that Valencia's Indice has an integrated model with integrated DocsMe, with RCT, and one other one, I think Zoom as well. So, the technology suppliers themselves are starting to align with that thinking, but it all has to happen at once. The ministry doesn't actually fund virtual consultation, so it's self-pay only. But it's really interesting that people are choosing to pay themselves because it's convenient.
And there's no e-prescribing either.
No, there's no e-prescribing, that's right. It's all paper.
So, Alex, this question is for you. Sort of imagine a scenario where you can actually collaborate with all of the geneticists in New Zealand. knowing that genetic information about your customers, do you think it will actually enhance or like would you actually develop a new insurance plan for your customers? And for the audience, imagine if your insurance provider actually have your genetic information, and as some of you or all of you may know, like all of our diseases are mostly genetically predisposed. Would you actually willing to pay more knowing that they would cover your predisposed diseases, I would say? Like, do you have
Giving me
anything
a
on
very
that?
difficult question. I'll have to speak very carefully since I work for an insurance agency. I mean, genetic testing is here, and people are having that type of precision investigation. I think the move towards wellness prescriptions, which is what they're kind of generating out of those findings, to say, sure, just because you've got a predisposition does not actually mean you will get that thing. There are things that you can do in your life. You can avoid alcohol, smoking, you can exercise better, you can do different things in your life to kind of help with that. I think that it's a good thing to do, but I think that it does actually require curating by a medical professional, someone who can help explain it to people. I think if you're just given that information, it could be very confronting, and it could be, what if you thought you had a 70% chance of getting cancer in your 40s? I mean, what would that mean to you? It was just dumped on you, right? I mean, I think there's a lot to think through in terms of receiving that information. In terms of insurance companies, I know that they are thinking about the use of that. I honestly, genuinely don't think they're thinking about it in terms of constraining your policy benefits. I think they're actually thinking about it in terms of how can we help our population be more well. So therefore, where should we be investing back into the population? Well, definitely Southern Cross is thinking that. So yeah, it's a really tricky question, and then you've got the whole deal around if you find a gene and you can amend that gene, should you? That's an ethical question for you. And that is actually happening. Designer babies. Yep.
Just a really, really short story about the fact that when I was a fourth year medical student, I was bullied by a senior surgeon, and I would describe myself as a resilient individual. However, I experienced anxiety and panic attacks whilst I was working under that particular surgeon. And I went to the Dean of Medical School and said, look, I'm actually not cut out to be a doctor. I think it's me, I'm not good enough. And he said, no, this guy's a non-bully, you're just going to have to toughen up. And I thought, oh my gosh, if I'm experiencing this kind of anxiety, then what are other people experiencing? So I started doing some research and realising that actually in healthcare professionals there's a huge rate of burnout, there's a huge rate of depression, and female physicians are 2.1 times as likely to commit suicide than other professional groups. And then sadly, 6 weeks before I finished medical school, one of my colleagues passed away due to a suicide. So it all became very real, and I decided that enough was enough. We're going to do something about it. So we started to get groups of medical students in and say, hey, what do you want to help with your mental health? And they said, we want an app. And I said, oh no, you don't want an app. There's an app for that, you know. And they said, no, we want an app, and we want to be able to tell the places like medical schools or hospitals what's going on for us so that they can change things. And we also want a notification to tell us when we're actually stressed and where and how to get help. So I said, okay, all right, well, let's keep it real simple. So I got another medical student, and we designed the first MVP app. It was called Participate, and that was used in Middlemore Hospital by junior doctors and new graduate nurses in Middlemore for a year, and also the medical students in Otago University used it. And I was really blown away. People actually used it and found it really helpful. And I presented it, like all good medical students do. I presented it at a conference in Australia, and I just got inundated with people saying, hey, we really need something in our hospitals to help healthcare professionals. And so Channel was born, and now I'm working with, I do some research with health informatics at Auckland University, and so now working with uni services, we're commercialising it, and looking at getting that out into DHBs, and even had some interest from Australia and from America. was contacted by Harvard saying that they want to trial it with their medical students. So really exciting stuff, and now I'm in this dilemma of, do I continue with my clinical medicine, or do I do a detour and focus on this? And I've chosen at the moment to do a detour.
Yep.
Yeah, and it's probably going to end up more than a detour, but I'm really passionate about this health technology space, and I think that healthcare is going to be totally disrupted, and if clinicians actually don't get on this train, then they are going to be left out, and I think that's a really sad thing. So yeah, we're all going to learn a bit more about health, and I'm just going to do a big plug at the moment for Health Informatics New Zealand. Anyone here a member of Health Informatics New Zealand? Hands? Yes, very good. Are you guys going to the conference?
Yep.
Yes, I'll see you there. So I've been on the board of HIMSS for the last 2 years. I've been a member for 5 years. Now this is the largest association in New Zealand for health technology, and it's not just for clinicians, it's for everybody, and it's one of the largest conferences in New Zealand. We are so big that we have to go to Mystery Creek because we don't fit anywhere else. And that's really exciting. And if you want to hear about all these cool new things happening, you'll get a lot of academics that are presenting all their new research that's coming out. You'll get all these new startups. They tell about what kind of things. Like Sarah Zubb, she was supposed to be here today. She works with Benza, and that's an incredible startup. And they're doing really, really well. They started off in primary healthcare doing a text to remind program, and now they've found that that's been really successful. So they're going further with that. So yeah, it's just a great place where people can come together and learn more and talk about these kind of things. So there's also 10 scholarships for students. So if you're a student, you can jump on that. And also they've got discounts available if youth funding is a problem, because we want as many people as we can to communicate to each other and connect in this community. Stop working in silos and work together.
So to actually wrap up, so what do you think is the ultimate goal of democratization data? And for now, what steps should healthcare providers and also patients should start doing? It could be
can I go on a tangent for a minute? Have we got time? No. Education. Really passionate about education. I think if we're going to give people access to their data, they're going to have to learn a bit about basics of health, and so that needs to start in primary school, it needs to start in secondary school. Health literacy is quite low in New Zealand, and so if we are going to give them access, then we need to have a way of communicating. It's like what you're saying with the genetic codes. You just don't want to find out these really scary things without having some education around it.
I think it's about rethinking how technology fits into the way we deliver care. Because I don't think it's one or the other. We often talk about tech or healthcare delivery, but actually they're the same thing. It's just figuring out how it works together. And I think that we're on a journey with that, and I'm not sure we are there yet. But I think democratization of health data is something that will emerge. I don't think you can say it is this or it is this. It's definitely about making knowledge available through education or through technology or through guidance, but I don't think you can separate the journey of a practitioner who cares and empathises with somebody from their data, their quantitative picture of their health. And how we work that together, that's the challenge for the next decade or so. There are several pieces of legislation that cover the use of health data in New Zealand. There's a Privacy Act, there's a Health Act, and then there's an amendment. I don't know what it's called. But essentially it describes the use of data and what it should be used for and what it should be collected for, which I'm sure you know. And so I would say that we're quite cautious in New Zealand about that. So every tech project I've ever been involved in requires us to understand how we capture the data, by which mechanism, where we store it, and what are the mechanisms by which we use and present that data back. And there are various mechanisms for that. You can do risk assessments, you can do privacy impact assessments, you can do a multitude of things. But definitely in New Zealand you cannot ignore the fact that we have some quite significant legislation around privacy. And we are also now, with, is it the, I can't remember the act overseas, anyway, the new legislation in Europe around
GDPR.
is that we're getting patients from those countries here, and we are delivering care in different regions, not just necessarily New Zealand. We actually have to think about compliance with international privacy law, which is another whole complication.
Yeah, I was just going to raise a point about the GDPR. So if you have a European person in New Zealand, they still have to comply with the GDPR. So basically we just decided you have to comply, which is actually quite a good thing, really. And then in the States, the HIPAA compliance is there, but that's not as robust as the GDPR. But I think Jacinda Ardern, she went across and she talked with, was that Paris? Which she was talking about?
Paris Accord or something.
Yeah, and about how we should have a one kind of international standard around privacy data. And I was talking to the girl on a plane. Best conversation sitting next to people on the plane, and she was with Internet New Zealand, and that's one of the internet providers in New Zealand, and so she was going off overseas writing policy around that, and she was lobbying for the WHO and the UN to actually lead that charge and saying what is the standards for privacy worldwide.
There's one thing I'd like to add to that though, is that legislation or people who interpret that for making regulation are very conservative in their interpretation of it. And so I think we still have to think about what is the intent of the data use, because we should be sharing health data for good purpose, and we should consider the risks of not sharing data, but it's got to be within the context of the use of it. So it's always a balance and it's always a bit of a battle. And I think in New Zealand, the public health sector is far too conservative in their thinking, and the private tech sector is far too ambitious.
Question for both of you guys. Have you seen any overseas examples of how the public might be able to access their healthcare data? And it might not be an overseas example, but how do you think it should work in New Zealand?
You can probably speak more to the Epic example. So Epic, I had a little demo when they came over to HIMSS conference, and basically they had it. You could sign into your portal and you could see your health record, and you could choose to share parts of it. You don't have to share the whole thing with the health provider. You can share just parts of it, and that was cool. It was interesting. It looked like it was from the 90s. But apparently it works really well, and people that use it have got great feedback. There is MedTech in New Zealand, which is one of the main software that GPs use, and they've got Manage My Health, which is a little plugin that goes into that, and you can log in. But I haven't really come across many patients who have been able to share that easily. You probably can talk more.
Yeah, there's in primary care there is a movement called Healthcare Home, and as part of that, it's actually an American movement which looks at your general practice being your healthcare home, as it says. But part of that is making something available called Open Notes, which is being able to read and use your own GP notes. I think it's called Open Notes, the program that they use, and you can serve it up out of any PMS. And so a lot more GPs are doing this now. But in terms of which the second part of your question was, how would it help if you could access your own health information?
The second part was just if you guys could design a system, how do you think it might work?
If we could design a system, it would be a system of record that follows a person. And there would be no need for e-referral anymore, no need for referrals of any kind. You would just be able to, through permissioning and through access, be able to control who had access to that data. And pretty much some of the big systems like Epic do run like that. I'm not saying that's the be-all and end-all, because I think it's quite an old piece of tech now. But there's lots of new and more modern ways that you could achieve that. But I think having transparency across healthcare provision of the information that belongs to you helps you get better care. And if you can see what is happening to you also, then it also helps you. So I think it can only be a good thing.
This is really exciting. I think this is for you guys in this room.
Yeah, exactly.
I'm really keen to hear your ideas. I know that you are probably using the data, and so I'm really keen to hear about UX, UI, and making sure that it's actually usable for people. Hence my comment about how Epic looked like it was from the 90s. I think it really needs to be something that's easy to use and simple and easy to understand. Just like fintech, like you probably don't even remember the times when we used to have to go to the bank and get little printouts and put them in a little passbook to get your bank statement. And if you were to move money around, like you'd have to go into the bank and give them the number and have checks. And like that was like when I was in high school. So now I didn't even consider going to the bank to get a printout of my statement. It's just all on an app on your phone. That's really simple and easy to share. And so I think we could really take some learnings from fintech.
So, in answer to your first question, the law actually doesn't allow private companies to access the national data sets, which I think is a real flaw. Because in New Zealand, the health ecosystem, we all need each other to deliver. We need private and we need public, and we need us to work together. So ACC has managed to get a dispensation to the legislation where they are now allowed to access the data set. Southern Cross will be thinking about how to get a dispensation for that as well, because they could legitimately ask each of their members for their NHI number, but occasionally those numbers do change, so you want the source of truth. So it's legislation that prohibits that. So research shows us in insurance anyway that people do share information that you think they would withhold because they're afraid of being found out later when they actually do need to be covered. So people genuinely are quite honest about their cover. The only time they don't share information is usually when they didn't know they had to. And that's about insurance providers being clearer. But our actual experience tells us that people generally tend to be quite honest in that space.
Interesting, I read in that article in the paper just the other day about IAI insurance. And they were saying that it was like an op-ed about somebody who had signed up to their app, and every time they did exercise, they got so many points. So many times they went and visited their GP, they got so many points. And then when they got so many points, they got that much money taken off their insurance premium. So it's an interesting way. I think this is the start of it, that we're going to be given discounts for being healthy. And the person who was running the op-ed said he was initially very dubious, being like, I don't want them to have my data. And at the end he was like, actually, it encouraged me to take the stairs instead of taking the lift. It encouraged me to eat healthy because I was actually getting a financial benefit and I was getting a health benefit. So actually, overall, I'm happy to share that information with my insurance company.